Now the question is, would you fail this heart failure question? Let's get into it. A 59-year-old man is reviewed on cardiology some 10 days after suffering an anterior myocardial infarction. Stented initially, and although he remained pain-free, there was some evidence of left ventricular failure. His current medication is dual antiplatelets, ramipril, bisoprolol 10 milligrams, atorvastatin 10 milligrams, and furosemide 40 milligrams. Blood pressure is normal, pulse rate is 75 and regular. There's bilateral crackles to the mid-zones consistent with cardiac failure. Right, so he is decompensated a bit. Now, looking at his blood, it looks grossly normal. His potassium is normal. Creatinine is slightly elevated. His ejection fraction on echo is 30%. Now, the question is, which of the following is the most appropriate next step for long-term improvement? Now, again, I have another video that I'm going to post at the end of the video, specifically about how to approach MRCP questions, but we're not going to get into details here, but I'm going to demonstrate it now. Now, we talk about approaching questions with the right clinical decision making. Now, remember, you are a clinician, so you need to have your clinical reasoning with you when you answer MRCP questions. Now, common sense things, things that you can clinically rule out even without having deep knowledge of that subject. Okay, that first, good clinical decision making. And number two is working to eliminate wrong answers to reach your correct answer. Now let's apply that here. Now the question is, what's the most appropriate next step for long-term improvement? Now this is very important. It's not asking what are we going to do to get rid of this excess fluid. It's asking what's going to help in the long term. Now, just looking at these options, furosemide is just going to offload fluid. It's not going to do anything for the long term, so we can eliminate furosemide. Digoxin is only for symptomatic relief, so we can eliminate digoxin as well. The patient is on 10 milligrams of ramipril, which is a high dose of ramipril. If we add valsartan to it, that's going to tank the kidneys. The renal function is already, creatinine is already a bit high. So we can also eliminate adding valsartan. Now we're left with B and E. Do we add eplerenone, or do we switch ramipril to valsartan and sucralfate? And that's where we're going to go through the current management of heart failure. Okay, and we're going to go through MRCP Updates online textbook that's very up to date and contains the concise information you need for your MRCPs. Hold that answer now. And let's go through the management of heart failure. Now, heart failure by definition is a clinical syndrome where the heart cannot pump enough blood to meet the body's needs. We can classify it categorize it either by ejection fraction, by timing, and also by anatomical involvement. Now, classification by ejection fraction is most common. We have heart failure with reduced ejection fraction, HFrEF, and heart failure with preserved ejection fraction, HFpEF. Now, HFrEF is ejection fraction less than left ventricular ejection fraction less than 40%, and this is a problem with systolic dysfunction, right? The systolic part of the heart is not working. The systolic phase is the problem. So we see this often after ischemic heart disease, where there is a trauma to the ischemic injury to the left ventricle, causing a lot of the cardiomyocytes to die and to cause a left-sided failure. Now, we can also see in dilated cardiomyopathies, myocarditis, and in arrhythmias. Where in HFpEF, we have a diastolic dysfunction. So the left ventricular ejection fraction is okay, but there is a problem with diastolic. There's a problem with the ventricular filling. Now, we often see this as a consequence of long-standing uncontrolled hypertension, right? We also see it in hypertrophic obstructive cardiomyopathies, and anything that's causing a restriction. So tamponading or constrictive pericarditis or restrictive cardiomyopathies. Now, borderline or heart failure with moderately reduced ejection fraction is LVEF between 40 and 50%. Now, other ways to classify it is acute and chronic, right? Acute decompensated heart failure where there's pulmonary edema and severe dyspnea. That requires emergency care. That's not what we're talking about here. Here we're talking about chronic heart failure. And this is progressively getting worse shortness of breath, orthopnea, exertional dyspnea are the increasing peripheral overload are the common presenting symptoms. Now we can also classify a left-sided and right-sided. Left-sided heart failure presents as pulmonary edema, where the left ventricle is not contracting well, so there is a backflow of blood into the lungs, and this causes a fluid overload in the lungs. Symptoms are dyspnea, orthopnea, and bibasal crackles on examination. Where in a right-sided heart failure, the right side is not able to contract effectively, mostly as a secondary to left-sided heart failure or to long-standing pulmonary hypertension. So you get fluid overload, so peripheral edema, raised JVP, ascites, weight gain, hepatomegaly, etc. You also have biventricular failure, often as a consequence of long-standing left ventricular failure leading to right ventricular failure as well. I'm going to shortly mention MRCP update here. The online textbook shown here and the questions in the beginning are from MRCP updates. You can subscribe using the link below and you'll get a 10% exclusive discount. They have thousands of past paper questions with elaborate explanations and an online textbook that's ideal for visual learners. I personally used MRCP updates for my part 1 and part 2 preparation. It's a great resource and I recommend starting 3 to 6 months before your exam. If you're unsure how to start your preparation, at the end of the video I'll put 2 videos on the screen, one for part 1 and one for part 2 preparation, where I outline a plan for how to prepare. Now going back to our heart failure, regarding management, this is our the big question: how do you manage chronic heart failure? So you have your 4 pillars. First lines are ACE inhibitors and beta blockers, right? If ACE inhibitors are not tolerated, then you can have ARBs, beta blockers. After that, we've got your mineralocorticoid receptor antagonist, or also known as aldosterone antagonists, such as eplerenone and spironolactone, and your SGLT2 inhibitors. That's exceptionally great for diabetics because it also gets rid of excess sugar and helps control blood sugars. So these 4 are the 4 pillars. Now they are, the reason why they're called the 4 pillars is that they have established prognostic benefits. So everyone should be, everyone with a heart failure with reduced ejection fraction should be on the 4 pillars. Now this is again all for HFrEF. HFpEF, you concentrate on symptomatic management, but with HFrEF, every patient should be on these 4 pillars. Now, going back to our question, the patient was on bisoprolol, on ramipril, so 2 of the pillars. They weren't on a aldosterone antagonist, eplerenone. So we can start the patient on eplerenone. We have to make sure that the potassium is not too high. Because it's an aldosterone antagonist, it's going to drive the potassium up. The potassium here is 4.1, so we can give eplerenone. Now, if with the 4 pillars, the blood pressure, the heart failure is still not controlled, so often with an ejection fraction of less than 35% and maximum dose of all the 4 pillars are still not controlling the symptoms, then we have often 2 add-on treatments that we give. One of them is option E in the question, valsartan sucralfate, also commonly known as Entresto. Now the valsartan is an ARB, but the sucralfate is a natrilysin inhibitor. It prevents the breakdown of natriuretic peptide, and is very useful in patients that are not controlled on ACE inhibitors alone. Another alternative is Ivabradine, which is a funny channel inhibitor. Now these can only be used if the heart rate is above 75 because they could cause bradycardia. Okay. Now again, another third add-on option is CRT, cardiac resynchronization therapy, and we often use these if the ejection fraction is less than 35%, if there is QRS prolongation more than 130 with a left bundle branch block. And of course, lifestyle modifications and regular physical activity as tolerated. Now, some exam tips, differences. As we mentioned, the common causes for HFrEF is ischemic heart disease, for HFpEF is hypertension. Management for HFrEF is the 4 pillars, for HFpEF is the symptomatic management. We mentioned device therapy, investigations with your BNPs and regular blood works, with echoes and chest x-rays. And often in exacerbations, it's important to check for medication adherence and any ischemia, arrhythmias, or infections that could exacerbate the heart failure. Now, on the screen, on the left, I'm going to put another video where I go over 5 MRCP questions from MRCP Update in detail, explaining how to approach answering the question. And on the right, I'll put 2 videos, one for MRCP Part 1, one for MRCP Part 2 preparation, where we go through what to do in detail. All right, that's it, folks, and I'll see you next time.